I'm Dr. Timothy Johnston with Part 4, Module 4 of our amazing customer service team training for general dental practices. We spent a lot of time in Modules 2 and 3 on the first appointment of hygiene, some recare appointment business as well, but really that was pretty contained. There's a bunch of other stuff that happens in hygiene on a day-to-day basis that doesn't fit in that category, so I thought I'd address it with other hygiene-related issues. It's what happens in the hygienist's chair an awful lot that raises questions and perhaps could hinder you providing amazing customer service. So let's talk about that and make sure that you're going from average to amazing. Number 1, my patient forgot to take his pre-med. Can he still be seen today? Is that a no? Kicking him out the door. A lot of dentists, you'd be surprised, agree with this. You didn't take your pre-med, you got to go home. That's not the case at all. Let's look at the science. The correct term for pre-med is actually prophylactic antibiotic therapy. It doesn't say 1 hour before therapy or pre-appointment therapy. It's just prophylactic. What are we prophylaxing against? Bacteria being introduced through our services of scaling and cleaning or even just probing, bacteria going through the bloodstream and collecting on their heart valve or on a prosthetic joint. That's what we're doing. The science says it does not need to be taken prior to the appointment. Anywhere between 1 hour before and 2 hours after is an appropriate time. That means you can give it to them right in the office. We keep a collection of antibiotics, amoxicillin, Z-Pak, azithromycin, and Cleocin in the office at all times so that we can provide that to our patients. Some of them, I know, don't even bother to fill their prescriptions. They just always come in and say, oh, I forgot, because they know we'll give it to them. And who cares? It's what, a penny a piece for amoxicillin? It's cheap, and that's good customer service. If that's not what they want to do, let's say that we're out of clindamycin for some reason or whatever. We give them a prescription, they go to their pharmacy and take their prescription amount right then and there. I tell them, buy a bottle of water and drink it before you leave the store. Or if it's at home and they forgot it, I say, just go home when you get done here and take your antibiotics then. It is science at work. This is the time range, not what we were taught in dental school. They must take it 1 hour before. Because what if you're running half an hour late? Is the 1 hour the critical part? No, we all know it's not. What if the patient is already on an antibiotic for something else? Oh, I had strep throat last week and my doctor gave me some Augmentin. You say, okay, well that's amoxicillin based with something else. I don't think that's the right course for Augmentin, so don't quote, or for strep throat, so don't quote me. Out of my realm. Do they still need to be pre-medicated for their, or prophylactically therapeutically medicated? You get me. Pre-medicated for their artificial joint or heart valve? The answer is yes, they do. What happens while you're taking a 10-day course of some antibiotic is you're always selecting out a few strong guys, so a few strong swimmers. These are the ones that are resistant to whatever medication you're taking, and they will take up opportunity to lodge in a heart valve or a joint or whatever you're pre-medicating against as soon as they get a chance. So you're selecting out with that week or 10 days of therapy the strongest bacteria. Now let's say they do get an actual infection in there, it's going to be way harder to kill it off. So what you want to do is have a different second antibiotic just for their prophylaxis. So if they normally take amoxicillin for their pre-med, and they've been on amoxicillin or Augmentin, which is amoxicillin plus glutamic acid, then you give them azithromycin instead, or clindamycin instead, for that one bolus, that one dose of that medication to cover them for their antibiotic prophylaxis. Right? Has to be done. Otherwise, you're selecting out for a real problem. They still have to take what I just said right there, they still have to take a prophylactic, but it could be something different. Here's a question. What's the best time to schedule a recare appointment? It's right now. Right now, while they're in the chair, right now before they leave. And who better to schedule the next recare appointment than the hygienist who just saw the patient? Well, Dennis, that's his name. Dennis, is 6 months, are Tuesdays good for you 6 months from now? He'll say, sure. Like today, is this time of the day best for you, 10 o'clock in the morning? Sure, great, I've got you 6 months from now on a Tuesday at 10 o'clock in the morning. Fill it out, here's your card, see you in 6 months. And Dennis likes his hygienist because she's built rapport, so it's not like the front desk is trying to badger him into an appointment. She's going to get it taken care of now. That's good customer service because he'll be back on time, and we save the front desk the hassle of having to do one more job. They're always overloaded as it is, answering phones and checking people in and out. So if we can take a little bit of the heat off them in the back office, we will, and Tammy's the best person to get Dennis to commit to his next appointment. When scheduling the next appointment, it's time to erase the notion that every single recare needs the same amount of time. Whether it's an hour or if you only allow 40 minutes or whatever it is. Why? Why is that? Because that's the average? Well, don't schedule everybody on the average. It takes an hour to clean these 3 teeth? I don't think so. Number one, he's doing a good job already, and there's only 3 teeth. Even if you throw in the oral cancer screening and maybe 2 x-rays, whatever, You couldn't possibly spend more than 30 minutes, and 10 of that's going to be talking about whatever they've been doing lately, checking to make sure the dentures fit well and all that. You couldn't possibly take an hour for there. But that patient, and that's a pretty standard oral cleaning, that's some coffee and wine and a little bit of tartar. This is not periodontal disease. This is a typical 6-monther walking in. That's probably going to take you 45 minutes to an hour to get all that cleaned up and do all the rest of the stuff that happens in the appointment. So why do that and that both get the same amount of time in so many offices? I don't know, and it doesn't happen in my office. The hygienist who just finished seeing the patient will look at her watch and see, I only took half an hour for that. Well, dentist, next time I see you, we're going to schedule you for 30 minutes because that's all the time we took today. She may not even say it, but she's going to control her own schedule 6 months from now so that it is full and so that she can see everybody. That gets more important to them when they're working on either a bonus or a commission system versus a base salary. I can tell you that from personal experience. That's a conversation for outside this topic, though. Patient says, I don't know what I'll be doing 6 months from now. Best line ever. Ready? 3 words. Now you do. Because you're going to make appointments, you're going to have stuff come up, whatever. But if you put this on your calendar, you'll avoid making those other plans next 6 months from now on a Tuesday at 10 o'clock. You're going to say, someone else is going to say, you want to go and get a coffee next, oh no, I've got a dental appointment that day. So I don't know what I'm doing 6 months from now. Now you do. Say that, you'd be surprised. It gets a little chuckle, and it works. What is your pre-scheduled ratio? In other words, how many of your people leaving today have appointments 6 months from now or at some point in the future? Who is pre-scheduled? Do they leave and go, I'll call you when I'm due for cleaning? Or do they leave and you say, we'll call you in 6 months when you're due for cleaning? Or do you pre-schedule everything? Again, this was delivered to my office at a seminar that I gave for all my staff members, and I brought up some of our own numbers. I'll share them with you today as well. The recares who were seen in July and August of that year were 1,695 adult recares. There were 1,555 recares scheduled for their next cleaning, which is a 91.7 success rate. That's pretty darn good. Not everybody will adhere. Not everybody will schedule. Some people aren't coming back. Some people know they're not coming back. Might be for a good reason. They're moving. Or maybe they just only go every 5 years because they don't think they need you. Whatever. Some people are not coming back or can't schedule today. Listen, I think we're getting deployed sometime in the next few months. I'm not going to make that appointment. I'll call you if we're still here. Oh, that's a valid reason. We never push or pressure anybody, but we offer and suggest because that's good customer service. Here's a question. Are hygienists allowed to diagnose? I know the answer is no. But does charting and diagnosis equal the same thing? No, it does not. You may chart all day long. You may chart red marks on that computer screen or on a paper if you're using it, whatever. I love this. Dental hygienist learns pharmacology and pathology, can't prescribe or diagnose. True statement, right? Kind of like dentists in Virginia can't give Botox. You know what the statement was? They don't really trust us around the face with needles. Who has more experience around the face with needles than us? But in Virginia, dentists are not allowed to give Botox unless you're an oral surgeon. Whatever. So, charting does not equal diagnosis. Please chart your little heart out, hygienists. Get it on paper because your dentist wants that information. He wants to know what you saw. Again, I mentioned it in the previous module. If you spend 2 or 3 minutes on each and every tooth, that's way more information in your head than the 2 or 3 seconds I'm going to spend on every tooth unless you've already called my attention to it. So chart everything. You're not doing a diagnosis. You're suggesting that I look closely at something. That's it. Here's the pre-diagnosis, as we would call it in my office. That's your charting. And then after the doctor has been in there and checked everything and made sure of what's going on, then we get to the diagnosis page. Do you see the difference? I'll click back and forth between them. Pre-diagnosis, diagnosis. What's the difference? Well, in that picture, the picture moved a little bit that way. I guess I wasn't centered up. Otherwise, it's exactly the same thing. How often does your doctor change what you've diagnosed, what you've charted, or pre-diagnosed? Almost never. You hygienists are very well educated. You are just as smart as anybody about what's a cavity, what's broken, and if you've worked with your doctor long enough, you know the treatment that's going to happen as well. If you don't, we're going to get to that about some synchronization of minds, but pre-diagnose everything you can, please. All right, hygienists, assistants, and doctors. This is for all of you. How well do you know each other? I mean, really, truly, do you know what the doctor is going to suggest when he comes in and sees a broken cusp? Assistants, do you know which chemicals the doctor likes for what kind of a filling? You should if you've been there for a while. And if it's still a big mystery, then you need to learn to communicate. How well do you communicate with each other? Because if you haven't trained each other in what your habits are, every day is going to be drudgery. Every day is going to be a new show to put on, right? My two primary assistants that I work with, again, we have lots of doctors, lots of assistants, but we try to be consistent. So my two assistants, Wendy and Amy, we could go an entire day and not talk dentistry. I know this for a fact. We often go through a whole procedure and not talk dentistry. I don't need to tell her that I want microprime and then your bonding resin and I want to dry it first, then you can cure it. We've done these things 10,000 times together for some of these procedures. If they still don't know what I'm going to do next, shame on one of us for not communicating that properly. So we've trained each other over the years to know what's going on. Have you communicated all your thoughts on these items? Because it's important, not just what chemicals come first. What about non-surgical perio versus surgical perio? Where do you fall on that, dentists? When is surgery necessary for either perio or, say, getting a tooth out? When is a surgical extraction versus a regular non-surgical extraction? When to refer? What level are you comfortable to? Because your hygienist will say, if you don't do root canals, because some dentists don't, your hygienist might say, yes, there's an abscess at the bottom of the tooth. I know when Dr. Johnston comes in, he's going to want to refer you to an endodontist for that. Okay. Now, I do root canals, so my hygienist would never say that or I'd fire her. But when to refer, does your doctor know, or does your staff know, doctor, when you prefer to refer out? What are your limitations? What's your comfort zone? When to crown a tooth versus refill it? There's some very specific guidelines on that. When to replace a filling, again, versus crowning it. When to push. So when do patients need a little bit of pushing? I've got a patient right now that has an abscess over tooth number 14 in his mouth. I have a CAT scanner in my office as well. I saw that there was something on a PA or on a bite wing. We took a PA. There's more beyond there. I took a CT scan. He has destroyed the cyst has destroyed the bone between his sinus and his tooth, and now it's destroyed the entire buccal plate as well. He won't do anything about it. Am I pushing? You bet I'm pushing. This is in this patient's best interest to let me or somebody get this abscess and cyst and tooth out of his mouth. He went to an ENT who looked up his nose with a scope and said, I think you're fine. That's not a diagnosis. And then he tells me he went to an oral surgeon whose name he can't remember, and the oral surgeon said, oh, you're fine, don't do it. So what did I do? I took a secondary CT today, which is 6 months later after I found out he's just not coming back, and I'm going to go to his ENT and say, here's my data. Would you care to support me on this, or do you want to continue to say this patient doesn't need it? Push. That's a rare instance, I get it. A little more gentle instance might be a broken cusp with a leaky amalgam. You should push on that because that needs to be done. There's a great big amalgam with a little trough next to it. Okay, 6 months from now it's going to look the same. Tell your patient, this isn't a crisis, but you need to get it done. The other stuff, push on it. When to say good enough? There are times when my patients are just done with dentistry, at least for a while. I've done a bunch of work. There's some more work in there that could be done. It's coming, I know. Give it a couple of years, things are going to start to break down. But the patient is mentally exacerbated with the whole deal. Stop pushing. Call it good enough for now. Unless there's an obvious, you're putting the patient at risk somehow, then push. But if not, know when to say enough's enough. You'll get to it. You don't want to tick them off so much they leave. You want to keep them around so that you can treat the work when it needs to be done. But when to save and when to extract, you should make sure you communicate on those two things. What is your limitation for how far down a tooth has to be broken that you can still fix it and build it back up? For example, is a shearing fracture off the side. If it goes a millimeter under the bone, can you do crown lengthening? Sure. 2 millimeters? 3? 4? Percentage of tooth left, 1 to 1, or do you want like 1.1 to 1 or 1.2 to 1? There's some numbers that your staff needs to know about when you're going to do certain treatments. And if you've shared it with them, it also keeps you honest, because then you have a protocol in place and it's the same thing every time. You're not just winging it with each new patient. Furthermore, have regular staff meetings. I have a 2-hour lunch set aside every Wednesday every single Wednesday of the year. We mandatorily have a full-on, everybody involved staff meeting or team meeting the first Wednesday of every month. The other Wednesdays are set aside for other potential meetings. Sometimes hygiene will want to have just a hygiene meeting, or sometimes hygiene and doctors will invite us in to do some coordination of things. Sometimes front desk just wants to meet and talk about new insurance policies that have happened. I try to attend all of them as the owner of the practice, but sometimes I'm not invited. They just want to get together and do their thing, and that's fine. We order pizza in, or they get sandwiches, or whatever. I try to make it not pizza. No one wants to get fat anymore. So we're getting healthy food brought into the office. We have a team meeting. Every single Wednesday is available. We always take the first Wednesday. We sometimes take the others. And if not, we just have a nice long lunch. And that's okay too. Discuss clinical and business ideas. Again, the meeting is open for anything. Anything that affects our patients, affects the practice, we want to talk about it. Clip articles to read. This is one of my favorite things to do. I read all my journals and all that. There's a lot of good articles in there for the team, not just for the dentist. So I'll take and print off a list of all the people that it's appropriate for, maybe just front desk or maybe the whole staff. I'll print off that list. I've got multiple lists, multiple little pieces of paper. I'll paper or staple it to the article. And as you read that article, you cross your name off and hand it to somebody else on that list. Most of these I'm doing to the doctors. It's me and 4 other doctors. I'll find a lot of clinical things and say, hey, we should think about this, or here's a technique I've been watching. And I'll initial it, and they do it to initial it and pass it on to another doctor who hasn't seen it yet. And that way we've all seen the same materials. Maybe they get the same journals. Maybe not, they're reading the same articles. This way I know they are. And for staff, it's something really good. I don't even know what that was anymore. So dent and sensitivity. I want them all to read it. My hygiene and clinical team needs to read that so they know what we're talking about, and we try to eliminate sensitivity from, say, tartar-controlled toothpaste or acidic drinks, Gatorades, and diet sodas, things like that. When you do see, what do you see when you look at the same thing? So dentists and hygienists, when you see the exact same thing, are you thinking the exact same thing? Because that's not always the case, is it? I love these little things. Who sees a guy playing a saxophone here? Because that's pretty good. That's the first thing I see. Do you also see the shadow of a lovely young lady? The light would be coming in from this side and shadowing her hair here, her 2 eyes, her nose, her mouth. But the first thing I see is a guy playing a saxophone. What about this? I have a really hard time not seeing a frog. That's a frog. But if you just turn that picture a little bit this way, you'll see the horse's head coming out of the water. Nostrils, eyeballs, ears. Have you got it there? This is a classic. Is that a pretty young lady or an old hag? I always see the pretty young lady first. Maybe I'm just geared in that direction. Feather, a little bonnet, her eyes, her face is pointing that way. That's her neckline with a necklace and her like a big fur coat. Or do you see the hag? Here's her chin, a big witch's nose, 2 eyes, and her hair coming down. The hag is hard for me to see. I don't see ugly people. I see pretty people. And this one around the internet, is that a blue dress or is that I forgot what the other one is, because all I can see is a blue and black dress. I think other people see gold. I don't know. I'm not even sure how it's going to come across on this. I'll be curious to hear how people react to that. Here's clinical. Let's get clinical. Hygienist, I know what you saw first. You saw the wings of tartar in there and the progression of periodontal disease, the lack of the bony stability of the bone in through here. Dentist, I know what you saw first. You saw that big crater of a filling encroaching on the root canal in that tooth. So the first thing I see as a dentist is root canal, core, crown. I may have to do a little crown lengthening there as well. Hygienist, I know you saw first all the perio stuff. So do we see the same things when we're looking at the same things? The answer is no, almost never. Depends on how our mind has been trained, our experiences and all that. So the communication, the team meetings, is to make sure that we teach each other what we are seeing so that we are appropriate with our patients. Again, providing amazing customer service. And I just love this. Brush your teeth for 2 minutes, ain't nobody got time for that. I'm sure you all remember this girl from some fire up in some city, I forgot what, but ain't nobody got time for that, was her comment. That is the end of part 4 of my talk. Hope that's helped to sort of get some of these odd things off the shelf that coming up in play with hygiene appointments and to better educate the entire team so that we're all on the same page. I'll see you in Module 5.